see. How you doing, Regina?
This meeting is being recorded.
I'm good, thank you. Just studying some.
Okay.
Hey there,
Thank you.
guys.
Hi.
I'll be right with us here. I've got to grab a couple things online here, and then I'll be ready.
Okay, sounds good.
Alright.
Thank you.
All right.
Yeah. How many classes are you taking, Doris?
I'm doing advanced counseling.
Oh, wow. Do you like that? Or how was the class?
Well, the class is okay. I mean, we're trying it to do it as practical, just practicing. And I know this week we were in pairs, so we can practice, the real counseling, like one person to be a client and then the other person to be the counselor, and then vice versa.
Mm-hmm.
Yes, and then we can record that, and then we do a reflection paper on it.
Okay. So I'm trying to figure out, so have you taken, so have you already taken the child pathology with Dr. Armstrong?
No. I didn't.
Oh.
Somebody advised me that it goes together with this one, but it was full when I was trying to get in.
Mm-hmm. I'm just
You're
trying to
ready?
figure out. I'm sorry, go ahead.
So you've taken it already?
No, ma'am, I have not. I'm just trying to figure out when to take that advanced class. So I'm trying to get a handle on that. I guess I need to talk to an advisor to make sure I take it at the right time.
Well, it was pretty good. I mean, I didn't know what to expect, but it's the best counseling. It's like another regular class that you have to practice the counseling techniques.
Okay.
Yeah, like how you respond, the empathize with the client. I think that's what we're doing basically, so we can know how if you're in the actual room with the consumer and you're doing counseling, how you gonna start, how you gonna build that up until you finish.
Mm-hmm. Mm-hmm.
Yeah, that's basically I think that's what basically this class is. Like, how do you start a session until the end?
Right. Very
Yeah.
interesting.
Very
Do
interesting.
you start your practicum next quarter, or when do you start your practicum?
No, actually, I haven't put my introduction in there, but I was been busy trying to do it. I'm a little bit farther. I think I'm not closer to that. Maybe after this, and then after next semester, that I can see where I am.
Okay, very good.
Because when I started this, I should have really finished this one, but I got sick. Like 2021, the whole of it, so that put me really behind. I was very sick and didn't know we'll
Well,
go
good luck
back.
with it.
Huh? What do you say, dear? Regina?
Yes.
Yeah, so I was 2021 sick, but then as it was the end of 2022, I came back. So I'm feeling better. I hope I'll pull through this.
Well, good. Well, I hope so.
So how are your quizzes going?
Well, those things are tough.
Yeah, so I'm glad you through with the midterm, or you still working on it? I am working on it.
Okay. Actually, I am through with the midterm, thank goodness. So I'm working on the latter half of the class, but yeah, but I'm also in advanced ethics, so I'm writing a lot of papers. So that's kind of what I'm focusing on this week, is writing a paper.
Oh yeah, advanced. What is that? Advanced.
Advanced Ethics is with Dr. Ken Johnson, and it's a really good class.
Really
It's
good.
a lot of papers.
Oh, okay. Wow, that's interesting.
Mhm.
Yeah.
All right. Sorry for the delay there. I'm trying to figure out my Mac, and it's just not as intuitive as it really should be, and it's frustrating because it's my other PC has the ability to split the screen so I can see you guys and see my PowerPoint at the same time, and I can do that with the Mac, but it's just not as intuitive. So anyway.
Their new update
Um,
is kind of irritating with the whole like buttons at the top corner and all that.
They change it every time and just make it not easy on us. Well, how are you guys doing? I was kind of listening a little bit as y'all were chatting just then. Sounds like having a little bit of a challenge with some of the quiz stuff. Is that right?
Yes, yes.
Well, if you have any specific questions, before we wrap up tonight, be sure to ask me, because I won't give you the answer, but sometimes I can be talked into why a question might not be the best question. And all I care about, to be honest with you, is your learning and effort. And if those two things are happening, that might be worth some points. So, okay.
Sounds good.
All right. Well, as promised, I want to cover quite a few things tonight. I want to talk about autism and talk about schizophrenia, bipolar, and depression. We'll start with autism and probably even talk a little bit about intellectual developmental disorder. But I'm going to share my screen here. So you're going to need week 2, 3, and 4 PowerPoint slides if you want to not have to look at my screen, because I tend to not progress my slides. And by the way, I apologize if my dogs are going bananas in the background. My wife and kids are going to be coming in soon, and so they might be barking kind of loud. And so I'll try to get it to where we don't have too much of that in the background noise. Actually, let me do this. I can change that. I'm going to change it to. Yeah, I bet this works. Can y'all still hear me? Okay, wonderful. I turned up the background noise suppression. So we'll see. All right, and you guys can only see this PowerPoint, correct? Awesome. All right, that works. So let me start with intellectual disorders, and then I'm going to come back to autism, because IDD will take just a couple seconds, couple minutes to review and find where I wanted to go with that. Let's see. Yeah. All right. So intellectual developmental disorder, previously called mental retardation in the DSM-4. We don't use that terminology anymore, although you might still see it in medical records, and even physicians sometimes will put that there because they don't know any different. But that's the official diagnosis now, is intellectual developmental disorder, IDD, which is characterized by cognitive, neurocognitive impairment and adaptive functioning impairment, and as I would say objectively identified or assessed by a quantitative intellectual test, and usually an objective adaptive functioning questionnaire. So I do, and well, in the past, I did a whole lot of Social Security disability evaluations. Whenever I first started my practice in Paris, Texas, before I opened my practice in Wiley, for almost 8 years out there, I did a whole lot of those Social Security evaluations, and they required me to follow basically what the DSM has, where we'd have to administer an IQ test and give a formal like ABAS-3, like the Adaptive Behavior Assessment System, like a questionnaire, but it takes all of the responses, usually completed by like a guardian or caretaker or a parent or and so forth, takes all of their responses about that individual's behavior in several domains of like social functioning, functional independence level, you know, can they cook? Are they able to drive? Can they communicate? Social skills, and judgment, and then compares their responses about that individual to thousands of other informants who are reporting on healthy, normal individuals at the same age. Does that make sense? Okay, so that whenever I went to score that questionnaire, I could see if this person has objective impairment of their independence level, their functional skills. Because in order to diagnose an intellectual disorder, you can't just have intellectual deficits as measured by an IQ test. You also, those have to translate into day-to-day functional limitations. I've had several patients who had impaired IQ scores, but did not have actual adaptive functioning impairment. And because of that difference, they wouldn't be qualified as having an intellectual disorder. That doesn't happen very often, I'll be honest with you. And what I would say is the biggest thing that I want you to remember about IDD is that if you are working with an adult patient with IDD, and more probable than not, it's going to be mild, because if we get into the moderate, severe, profound category, that's where they're not going to be able to interact with you in a meaningful way as it relates to counseling. Okay. So if somebody comes in, or if you are looking through records and it just says, you know, intellectual developmental disorder, and doesn't tell you if it's mild, moderate, severe, or profound, if they're being referred to you, in most cases, you can probably assume it's going to be a mild severity. And by the way, I don't like the term mild because it sounds dismissive, but because it's a legitimate disorder, and it doesn't just affect them mildly. But at any rate, it is most likely to be in a mild category, which includes between a 55 IQ, which is less than the first percentile on an IQ test, all the way up to the 75th. I'm sorry. Less than first percentile is a 55 IQ. A 75 IQ is the 5th percentile. And so we're talking about, on the normal bell curve, a very teeny tiny piece of the low score there, or that range of scores is where mild falls. Now, the severity level of IDD is determined not necessarily by just the IQ test either. it's kind of a combination of both the IQ and the adaptive functioning again, because somebody could have a moderate severity IQ, let's say at, a 50, but their adaptive functioning is actually much better than what their IQ score is. And so that would offset the severity level to where they would bump up into like the mild category. Does that make sense? All right. Diagnostically, what you need to know is IDD is caused by anything and everything that affects the brain's development. And in most cases, I would say the vast majority of cases of IDD are caused by some sort of genetic syndrome. So like Down syndrome, Fragile X syndrome, Marfan, Mosaic Down. Yeah. And then there's also Angelman syndrome, Turner syndrome. Yep, quite a few. And also, in addition to the genetic, sometimes, what also causes it is prenatal complication. Anything that, exposure to toxins or substances while in utero, injuries or diseases of mom or the baby while in utero, or even anything that affects the brain substantially during neurodevelopment. And let me ask you this question. If somebody had a brain injury at age 16, and after the brain injury, their IQ is now impaired and their adaptive functioning is impaired, would they be diagnosed with a neurodevelopmental disorder? I'm sorry, would they be diagnosed with IDD, or would they be diagnosed with a neurocognitive or dementia? What do y'all think?
If it's an adolescent and they're younger than 18, then they can be diagnosed with an IADD.
Absolutely. And what about at 19?
No, you have to be 18 years old.
That was a tricky question. I'm sorry I tricked you there, Regina.
Okay. Well, no, that's fine. I mean, and so I am going by state standards. That's what I am doing, because according to the state, and I probably should have said that, but please tell me the right answer.
Sure. Well, and so the state, and you're right, the state is behind the times a bit, and so is the federal government for that matter. Because there is absolutely legal precedent out there, and I've been in at least 2 cases in forensic settings where neurodevelopment, and that's why the DSM-5 TR has expanded it and hasn't landed just on 18 as the cutoff, because the frontal lobe it keeps developing, and to say that somebody at 19 officially had their frontal lobe done developing, before they had a brain injury, is kind of just a guess. Now it's likely that, they had most of their brain development, but it wasn't completely developed. And so that's where the law needs those hard cutoffs, but the brain doesn't care what the government thinks about it. Unfortunately, I say, unfortunately. The challenge, though, is that we don't know exactly what that cutoff is. I mean, we could probably, it's pretty safe to assume probably at age 40 the brain's done developing. It's probably pretty safe to assume 35 is about right, but below that, there's some evidence that particularly men, their frontal lobes might not fully develop ever, which is kind of a joke, but it's true. Anyway, thanks for thanks for highlighting that, Regina, because and I didn't mean to ask you a trick question there, but it's important practically, because if, let's say, you're working with adults with IDD, you need to know that there might be opportunity for them to fight that cutoff as it relates to different legal implications of whether or not they receive Social Security disability benefits, like through Medicare versus Medicaid, because one goes, if they have a TBI, it goes to Medicaid. If they have a IDD, it would be a Medicare situation for Social Security. But anyway, with all that said, there are many things that can cause IDD, and IDD is just simply a label on how that person scored on an IQ test and adaptive functioning. Okay. Lastly, you need to know this too is important. IQ testing, in most cases, unless it's being performed by usually a psychologist, does not include effort testing. Meaning, as a neuropsychologist, I give tests that people without a brain can pass, that were designed for that purpose, so that I can see, if they fail that test, that means either they've got some severe neurological problems, and that's the whole point they're here, or they weren't trying as hard as they could. And so when that happens, I can look at the scores and know this is neurology and not just the person didn't sleep well last night, or they were trying to exaggerate how bad it is, right? That's also the case with kiddos. And so a lot of times kids get diagnosed or labeled as IDD in childhood who don't actually have it. They just were tested on a bad day. And that can also be the case too with adults. And so take it with a grain of salt, unless it's coming from I hate to say it because I don't mean to be biased here, but unless it's coming from a legit psychologist who seems to know what they're talking about in their report, take it with a grain of salt. Okay. Can y'all hear my dog barking? Oh, wonderful, because it's super loud. All right, let's talk about autism. Autism is everything we talked about with ADHD. So I want you to take that plate back out, look at it, all the stuff that we talked about, all the items on it. We're going to keep it, and then we're going to add another plate, okay? The other plate, and this is really where we're splitting hairs, is a pattern consistent with lifelong beginning in neurodevelopment, social skills limitations beyond what would be predicted if we just had ADHD. Okay. Now, with that being said, that's clearly different than what the DSM-5 says, because the DSM-5 goes into more detail about how you have to have fixated interest, rigidity to routine. You got to have, some speech language deficits, at least in most cases, and repetitive motor mannerisms. But the truth is that you can see all those things with ADHD. And so none of those by themselves, or even in a group necessarily, mean that the person has autism. In my opinion, and a lot of clinicians' opinion who work with adults with autism pretty frequently, it's the impaired social skills that separates the two. Now, people and adults with ADHD will have social skill difficulties. Because if you can't pay attention, you're not going to listen, and you're going to communicate sometimes in a strange way, because what you're hearing isn't what the person said, and so you respond to what you thought you heard, right? Or they have difficulty filtering out all the incoming stimuli related to the nonverbals of that person, and so they have a hard time prioritizing what's important to pay attention to while they're listening, right? Or they might miss the attention of or attention to and miss like well, I'm sorry, we already talked about that. They'll miss nonverbal cues because of working memory challenges while they're speaking. So with that said, we cover autism spectrum disorder in depth in the child and adolescent class, but as it relates to adults, what you need to know is that the vast majority of people with autism are on the high functioning side of that equation, okay? And so there are 3 severity levels. We no longer have Asperger's. That's an old diagnosis. We don't make that diagnosis anymore. We now have autism spectrum, and there's level 1 severity, which is the highest functioning, level 2, and level 3. Level 1 would be formally, in most cases, labeled as Asperger disorder. Okay. But level 1 is where the vast majority of people are with autism. And autism, on average, the average IQ for folks with autism is between the 16th percentile, just so you know, which would be an IQ of an 85. I say the average, that's the median, where the skew goes less than that, to where we've got quite a range, or the vast majority between like a 70 and an 85, which would be the 2nd percentile and the 16th percentile of their IQ. But I've also had people with an IQ of 150 with autism. Yep. It doesn't happen very often. But here's the thing is, the person with an IQ of, let's say, the 2nd percentile with autism, and the person with the IQ of 150, which would be the 99.99999th percentile IQ, those 2 people have almost identical functional impairment day-to-day life, and about the same level of independence, or at least the person that I evaluated, okay? In other words, autism itself is more of a predictor of a decreased functional independence level than even IQ is. Adults with high functioning autism, on the high functioning side, tend to be able to get a job, a lot of times go to college, maybe even get married, have kids, live a fairly normal life, although often need and rely on someone else for quite a deal of support and externally supplied structure. That you don't see very many of those folks, but there's a lot of people with similar traits, usually ADHD, in that category that will question whether or not they have autism. So you might work with an adult that wonders if they have autism. And if they have all those things kind of going in the background, that's a fairly rare level of function for true autism. And so I always lean more into the ADHD side of the diagnosis at that point. Okay. Everybody else with autism as adults, typically in the high functioning range, typically struggle independently obtaining employment or maintaining employment. There's often a quite a large discrepancy between what they appear to be intellectually capable of as far as career-wise or even academics as compared to what they're actually doing or able to do or not even able to do a lot of times for a career. They often struggle living by themselves. And this is where you'll see adults who are 40 still living with their parents. Yeah. If an adult is 25 living with their parents, just so you know, that used to be, I say used to be back in the day, 10 years ago, that used to be a soft sign that I would keep in the back of my mind to consider ruling out autism. But nowadays, with kind of the way the economy is, and how, just the debt situation for a lot of people, it's not uncommon to see people all the way up to 30 still living with their parents who don't have autism. It's not necessarily predicted anymore. But what you will see is a pattern of delayed milestone attainment as it relates to adult milestones. So like, when did they get their driver's license? It's oftentimes not until, 20 to 24, when parents were finally like, all right, you got to do this, and I don't care what you say. Oftentimes they won't take care of themselves with hygiene, and so they'll struggle even as adults, like without somebody prompting and reminding them and forcing them to take showers, brush their teeth, so forth. A lot of times they get hyperfixated. This is what I've seen with like young adults. They get hyperfixated on video games and will kind of hold themselves up in a cave, at their parents' house, and won't come out unless they're eating food. And even then, they just have like a hoarder's nest inside their room. You need to know that with adults with high functioning autism, OCD is a common comorbid diagnosis, as is ADHD. And really and truly, the research supports that everybody with autism has ADHD. It's just that it's its own unique kind of flavor. And so what's funny is that the research has identified that autism and ADHD are almost the same and probably are equivalent as far as underlying pathophysiology. But the difference being is that they'll admit that autism almost always goes with ADHD. I'm sorry, ADHD is almost always diagnosed alongside somebody who has autism, but it doesn't go the opposite direction. So if somebody has ADHD, that doesn't mean that they officially have autism, because autism is a higher level of dysfunction than even ADHD would cause. But they won't admit like OCD being the same part of the brain. And they won't admit Tourette's being the same part of the brain, or even bipolar for that matter, and schizophrenia too. The way I've conceptualized it is this way, is that, and this is what, like moving forward as we talk about depression and bipolar and schizophrenia, I want you to think through this. Autism goes with bipolar and schizophrenia and OCD. I'm sorry, Autism goes with schizophrenia. ADHD tends to go with bipolar. Okay, just remember that we're going to put those four together in their separate groups. OCD can kind of hit both of those categories, just so you know. You'll see people with ADHD with OCD, and you'll see people with autism with OCD, but not everybody with those diagnoses are going to always have it. Autism doesn't cause schizophrenia, nor does everybody with autism have schizophrenia. ADHD doesn't cause bipolar, nor does everybody with ADHD meet the diagnostic criteria for bipolar. But a lot of times people with schizophrenia who are diagnosed, when you look at their early childhood, if you could go back in time, they would have met the criteria probably for autism. Okay. I know I'm talking a lot, and there's a lot of information, but I'm trying to catch this up. One more thing I want to say about autism is that, and we haven't gotten there yet, we'll get there at the end of the semester, but there is a personality disorder called schizoid personality or schizoid personality disorder. That personality disorder was conceptualized or put into the DSM before we really had any idea about autism. Because I'm here to tell you that I have yet to find any research that can separate, from a neuroscience perspective, can separate schizoid personality disorder as being a distinct thing from autism spectrum disorder in adults. In other words, if you ever work with a patient who's been diagnosed with schizoid personality disorder or schizoid personality trait, that's probably autism spectrum disorder. And because schizoid is almost identical in its trait to autism spectrum. Okay.
Thank you for clarifying that. I was looking at the DSM-5 TR, and I saw that notation right above schizophrenia. But anyway, I think that's pretty interesting.
Yeah. What was that notation? Can you remind me?
Oh, so I was looking for some information about schizoid, and in the section prior to the schizophrenia diagnosis, it has a little blurb on schizoid, and then it says look in the personality disorders.
Mm-hmm.
Anyway, I just thought that was interesting.
Yeah,
just
and
all of just what you were saying about the link there.
yeah, and what's interesting too, so like so schizoid individuals, classically people with schizoid personality disorder often had schizophrenia as well. And that's the thing, is that autism and schizophrenia are enmeshed. They're not the same thing, but they share so much overlap that I've only had just a handful of patients who, with what I knew this to be true schizophrenia, and who didn't have a history of autism like trait.
Mm-hmm.
That doesn't happen very often. And so, and that's a good segue. So we're going to jump into talking about schizophrenia. Let me share get a new PowerPoint slide up here. There we go. So let's talk about schizophrenia and psychotic disorders. Another word for schizophrenia is what used to be called dementia praecox, or what means precocious dementia. And number one is that schizophrenia or psychotic symptoms and or manic symptoms or depressive, like severe depressive symptoms, result in cognitive impairment. Okay? Those disorders, I'm sorry, I said impairment, they result in cognitive decline. Those disorders, schizophrenia or having a psychotic episode, a manic episode, or a severe depressive episode, those three things, in a lot of cases, and perhaps most cases, result in a decline of that person's cognitive functioning. And in most cases, they don't return back to baseline. So just like COVID, right? So COVID, a lot of people got COVID. What we're finding out is that there's a substantial percentage of the population who got COVID who now have cognitive or had a decline of their cognitive abilities that they may not get back ever. So anytime anybody has a psychotic episode, which is most closely associated with schizophrenia, a manic episode or severe depressive episode, those things resulting in a decline in cognitive functioning in most cases, which is why they call schizophrenia dementia praecox, or the precocious dementia. And that's even accounting for medication effects, because what you also need to know is the medications used to treat schizophrenia and bipolar, the antipsychotic medication, especially the early ones, resulted in exacerbating cognitive decline. So like you could take a healthy individual, give them one of those medications, and if they took it long enough, it would make them have a slow, gradual decline in their cognitive abilities. The newer ones don't do that nearly as bad, but we also haven't had as much time to study them, and we're discovering that they're not as great as what Big Pharma promised as far as their symptom side effect profile. All right. Psychosis is not the same thing as schizophrenia, although it is associated with it. But psychosis can be caused by anything. In fact, if you've ever had your wisdom teeth taken out and they put you under general anesthesia, right? You probably don't remember much. But I can tell you, I remember whenever I remember kind of when I woke up as I was coming to, seeing like several, like a whole crowded room of people in there in the orthodontic surgeon's office who weren't really there. I saw a bunch of people that weren't there. Yeah. I remember asking somebody, or asking my mom later, I was like, who are all those people in there? She's like, what are you talking about? There wasn't anybody in there. Yeah. That was psychosis. That was a medication-induced psychosis. Or if you've ever had a night terror, or if you ever woken up and saw a shadow in your room and you couldn't move your body. Have you ever had that happen before? Yeah. You're going to hear people report that a lot of times. That's actually sleep paralysis, but what they report is waking up out of a dream and seeing a shadowy figure in the room, being terrified because they can't move their body. And then all of a sudden they kind of get up and they're screaming. And that's called a hypnagogic hallucination, which is a psychosis. And it's related to sleep, like usually sleep disorder and insomnia, sleep debt. Other things that can cause psychosis, any kind of underlying systemic disease that gets severe enough, especially if it gets into the bloodstream, often results in that getting to the brain and producing psychotic symptoms that are time limited. Okay. Additionally, you can have brain injuries that cause psychosis. You can have seizure disorders that cause psychotic episodes, even brain tumors. And absolutely several different medications and substances out there can cause psychosis. It's most likely to happen, just so you know, with stimulant, either stimulant medication or stimulant illicit substances like methamphetamine. So what do I mean by psychosis? Well, psychosis is a combination, in most cases, of when we talk about it, we're talking usually about the positive symptoms. So it's like seeing things that aren't there, having hallucinations, or hearing things that aren't there. But the positive symptoms, and this is how you can think about this, positive is like a plus sign, like we're going to add, like addition. And negative symptoms are like a minus sign, we're going to subtract. So when you see those terms, remember, it's not like positive, like, oh, that's great, you got those, you know, or negative symptoms like, oh, those are worse than positive. Positive symptoms are, you take your normal human ability and plus some sort of supernatural ability. So like, in other words, hallucinations, seeing things that other people can't see or hearing what other people can't hear, that would be a supernatural ability. That's a positive symptom. Or the ability to read people's minds, that would be a positive symptom. Or to have some sort of insight about, you know, the government's plotting like something against me or the people, causing a delusion, that would be a positive symptom. Okay. All right. Or receiving messages from the TV. And I'm telling you, schizophrenia in particular is associated with people getting messages from the TV. They subjectively experience that, and I've had them just spontaneously report that, just that specific thing so often. So if somebody ever says that to you, and if they're you know, telling you the truth and not just trying to exaggerate something, oftentimes that is almost certainly going to be schizophrenia in front of you. Okay. Negative symptoms are taking all of our functional abilities as an adult. Now we're going to subtract from those. So negative symptoms of schizophrenia or psychosis is going to be losing the ability to think clearly, losing the ability to speak. Let's see. We stop, you know, taking care of ourselves, stop interacting with other people, stop having an interest in social setting or social interaction, and or work, or our even like well-being, like physical functioning and personal hygiene. So if somebody starts dropping down, they were at this functional independence level and they just start slowly, gradually declining with those things, It doesn't mean they have schizophrenia. And in most cases, it means they have depression. But that is what's called the prodromal stage of psychosis.
Can you say that again?
Yep. So,
No, just the word prodromal.
prodromal. Let me see if I
Thank
can find that in my. Yeah.
you.
So schizophrenia is a specific diagnosis that is separate from just a psychotic episode. Having a psychotic episode doesn't mean you have schizophrenia. In fact, it's more likely that you don't have schizophrenia, even if you have a psychotic episode. Because we already talked about all the millions of things that can cause psychosis. But schizophrenia almost always begins with a prodromal stage of about 6 months to a couple of years of slow, gradual decline of negative and in other words, an increase in negative symptoms. So you start seeing a lot of, now we're losing our job, we're losing all relationships, and we're not coming out of our house. We're getting hyperfixated and obsessed about things and becoming increasingly more delusional, OCD-like. That's the prodromal decline. And there's a decline and then a sharp ramping up into a psychotic break. When somebody says somebody's had a psychotic break, what that means is they've transitioned from those negative symptoms into the positive symptoms, to where they started hearing voices, they started seeing things that aren't there, having delusions, so forth. That's usually when that person is hospitalized as an inpatient psychiatric, after which they return back into the negative side, or the negative symptoms being predominant, and usually on medication the rest of their life. Does that mean that the medication prevents them from ever having positive symptoms? Absolutely not. In fact, most people with schizophrenia will have breakthrough psychosis, even though they're taking their medication as prescribed. And so, but a lot of times it will just be a lot milder. And depending on how high their IQ is, if their IQ is higher, they often will still retain insight, even though they're having breakthrough symptoms. And so they'll tell you, yep, I can still hear the voices even right now, but I know that they're not real. The lower their IQ, they tend to have a harder time. They have a reduced insight level. But as we talk about bipolar here in a minute, I want you to think about this too as it relates to schizophrenia. In the psychotic stage, or the psychotic break, there's a ramping up that happens. Think about it like a bell curve. Along that bell curve, there's a threshold at which, when you cross it into the increased severity of the symptoms, part of that is losing insight into what's going on. And so if you've ever met somebody with who's in an acute manic state, or in an acute psychotic episode, they're not aware that they even have a problem. They are now living fully in that reality. They have lost insight. That is when we need hospitalization. People always ask me, how do I know when a patient who has, bipolar or schizophrenia, how do I know to make sure that they're getting to the hospital? Like, what's the cutoff?
my cutoff personally is if we are ramping up and we still have insight, if we can't get to our psychiatrist to modify our medication within like the next day or the next, the same day or the next day, we need to get to the inpatient hospital, because once they lose personal insight, they won't trust anybody, and that's going to be extremely difficult, if not impossible sometimes, to get them to go to the inpatient hospital to be stabilized. Okay, I know it's 5:57, and I've got another class I've got to get to here in just a second, but I can be about 7 minutes late. So what I want to highlight real quick, last thing with psychosis and schizophrenia, as we get older into like older adulthood, the chance that a psychotic break in older adulthood for the first time ever is due to schizophrenia is very low. The chance of it being related to a dementia is much, much, much more likely. So if somebody is 55 years old and they have their first psychotic break, I say 55 as if that's older adulthood. It's not really older adulthood. 55, let's say 65 plus, okay? Somebody 65 plus has their first psychotic break. That is going to be more likely to be some form of dementia or an illness, and in most cases, like even a UTI, like urinary tract infection, can cause psychosis, as compared to it actually being a schizophrenia. And so always be sure to find out, is this the first time it's ever happened, or is this something that's happened before? Okay. All right. Let me share. Depression and bipolar. And those are separated in the DSM, but really they're the same thing. And actually, I'm going to share a different screen. This is going to be better, and we'll end with this, and we'll still meet this coming Sunday. So we're going to be kind of wrapping up everything, given that week 5 is officially starting right now. But let me do this. There we go. If I can zoom in. Yeah. Does that zoom in for you guys too? Awesome. This is why I lump depression and bipolar together, is that they are opposite ends of the spectrum of the same underlying pathophysiology. And it doesn't mean that everybody with depression will have bipolar symptoms, but it does mean that everybody with depression is on the same spectrum as bipolar, meaning that they have an increased risk for, at some point in their life, having a manic episode or a hypomanic episode. And I'm showing you this zoomed picture here because if you think about mood in relation to dopamine levels, and one second, I want to qualify what I'm about to say with what I'm about to say is an oversimplification. but it's a good way to kind of conceptualize what depression and bipolar is caused by, even though it's not completely perfectly accurate. Okay, but it does work. It is accurate enough that we can say it. Depression primarily is caused by having not enough dopamine, norepinephrine, and or serotonin. I know there's some research out there, just, recently came out, so it's not serotonin, but there's also research came out like last week that says, actually, you're wrong. It is related to serotonin. It goes back and forth, has been for the past 2 decades. But for the time being, we're going to assume it is. If those neurotransmitters are low, that produces low mood, slow thinking, no motivation, irritability, increased anxiety, difficulty sleeping or sleeping too much, weight loss, having no appetite, or overeating, decreased sex drive, decreased concentration, and at least subjective memory difficulties. And if it gets severe enough, and how low it is, might include thoughts of death, feelings of worthlessness, hopelessness, and suicide. Okay. Now, when those neurotransmitters get too high, now we're talking about the opposite of depression. This is where that's going to produce very rapid thought processes, a flight of ideas, too much energy to where we can't sleep, decreased appetite, we're not hungry. Instead of feelings of hopelessness, feelings of ideas of grandeur. So we're gonna think that we can do stuff that we otherwise wouldn't normally think we could. We might even become psychotic. We might spend money compulsively or impulsively, make decisions that are just really bizarre and based on what appears to be very quick reasoning, engaged in repetitive, hyperfixated interest. And that's mania. So everybody on the planet, let me see if I can, I don't think Zoom lets me draw. Let me see. Yeah, I don't think Zoom will let me draw. Maybe it will with my, yeah, I'll have to do it next time, but I'll explain it like this, where everybody on the planet has a up and down cycle to those neurotransmitters, which is normal. So we have, seasons of life where we have more than normal, and so we're on the happy side. Seasons of life we're on the lower side. We might be a little bit not depressed, but just not, not ourselves. And that's normal to fluctuate back and forth. And by the way, there's actually truly a seasonal component to it, which is exacerbated by neurodevelopmental disorders such as autism and ADHD. With that being said, there's a fluctuation that happens. And the brain, when you're born, you get the genetics that tell you, okay, well, this range here is what you're going to get genetically. And then life shapes it in the frontal lobe up until 25, tells you, okay, this is actually what you need. Whatever happens in your life, from conception to age 25, shapes that pattern such that you design your own average, how much fluctuation. Obviously, childhood trauma, stuff like that, can cause some substantial fluctuation there, which can result in an adult or that person as an adult later on down the road having an increased risk for either depressive episodes or mania. And I'm going to have to pause it there because I've got my next class, but I'll wrap up with this and we'll continue this conversation about bipolar next time too. Depression and bipolar result in the longer those things go untreated, the more likely that person will continue to have those symptoms even with treatment. I'll say it again. The longer somebody is depressed and or hypomanic or manic without getting treatment, which is usually in the form of medication, but could also mean psychotherapy, the longer they stay in that state, the more likely they're going to stay in that state and the harder it is going to be to treat it. So if we have somebody who's 19 in their very first depressive episode of their entire life, and they recognize it right away, they get treatment, within a month. They've got an excellent prognosis because they're they may never have another depressive episode the rest of their life. But if somebody who's 50, who's had it, since age 19 without treatment, seeks treatment for the first time, it's gonna be a hard go treatment-wise. And it's not that it won't be successful, it's just that it's a lot less likely that medication or counseling is gonna do much in the way of changing that cycle. All right, I'm gonna stop it there, and I do need to switch so I don't get students, messaging me over in Moodle here. But thank you guys for letting me.
Thank you, Dr. Armstrong.
Yep, and we will continue this next Sunday. Okay.
All right. Thank you
Okay.
very much.
Thank you. Bye.
Yep. Y'all take care.